I want to thank the organizers and the community for inviting me to give this presentation and this wonderful session, Beats and Breaths, which coincidentally is also the name of Beyonce's next album. So I have no disclosures, and if any other Warrior fans are out there, I will be using KD in reference to Kawasaki disease and not Kevin Durant. That's the last joke I have. So, all right. I'm going to be reviewing current diagnosis, treatment, and long-term management of Kawasaki disease, and hopefully offer some helpful pearls along the way. You are all quite familiar with the 2004 document by the AHA, which is a great summary. And last year, the AHA released a very important bigger and badder update, 74 pages versus 26. So my goal is to hopefully try to distill this document down to the most salient and important points. And if you see that nifty new icon, those are the changes or updates that I thought were the most important for everyone. So we all know KD is a systemic vasculitis of childhood. And in untreated cases, we have some natural history data from Japan. 1 in 4 develop coronary aneurysms, and 1 to 2% have sudden death. It is the leading cause of acquired heart disease in the United States in children. And 5% of young adults presenting with a heart attack actually had lesions consistent with late Kawasaki disease. We still don't know the exact cause. It's most likely an exaggerated response to common antigen, and there is a clear genetic susceptibility and probably multiple possible triggers. I wanted to highlight one interesting epidemiological study. There were spikes in KD cases in Japan, San Diego, and Hawaii that correlated almost perfectly with large wind currents out of China and the Pacific. I'm not sure what was carried over in those winds, but it may have been contributing to some KD spikes. And also, KD is more common during the winter and early spring months. And having moved from California recently, we just call this winter in Michigan. And the US incidence is 25 cases per 100,000, less than 5 years old, which probably equates to about 100, 150 cases in Michigan every year. It's more common in boys than girls, and there is a genetic predisposition, so the relative risk in siblings is 10-fold higher than the normal population. And interesting, they did some studies in Hawaii. Children of Japanese descent had a relatively high risk, 202, versus the white children with a risk incidence of 14 per 100,000 per year. And there's more and more genetic polymorphisms that have been associated or linked with KD susceptibility. That if you're into that, you can look into the statement for more information on that. So this is a nice diagram that summarizes what we're learning about the pathogenesis of Kawasaki disease. And we all know that it's all about the coronary arteries and the potential damage in preventing that. So fortunately, the vast majority of children have no or transient coronary involvement with no lasting sequelae. However, there is an important subset that develop this thing called necrotizing arteritis, which can lead to important endothelial damage and aneurysm formation. And with that aneurysm, you create a substrate for clot and heart attacks. Also, some patients have chronic inflammation, which leads to proliferation within the lumen, and that can, over time, along with other risk factors, lead to complex stenosis. And some of these patients develop ischemic heart disease later in life. Those are the two biggest concerns with Kawasaki disease. Kawasaki disease is a systemic vasculitis, but the other organs seem to be relatively well protected. So on to diagnosis. Clearly the primary provider has the most challenging job because unfortunately the symptoms really do come and go and don't always show up at the same time. So the highest risk patients, the younger ones, often have the most nonspecific symptoms, as you well know. And all of us must maintain a high level of suspicion. So how do we diagnose classic or complete Kawasaki disease? Believe it or not, this is still the way Dr. Kawasaki did it in 1967, or reported it. So you need at least 5 days of fever and at least 4 of the 5 cardinal or clinical principal features. If all 5 principal clinical features are present, diagnosis can actually be made with only 4 days of fever. And let me gift you with this mnemonic hot cream. So this is the way I remembered it through pediatric residency and boards. Hot obviously is the fever, and it's typically high, spiking, and also intermittent or remittent. So conjunctivitis in KD is bilateral, and it does seem to spare the area around the iris. And an important feature is that KD conjunctivitis is dry and non-exudative. The rash can be almost anything. It is usually diffuse in macular papular in eruption. There is accentuation in the groin with often peeling later on. But one important note is that it is never bullous or vesicular or petechial. Extremity changes are the most distinctive feature of KD. And you typically have redness and swelling in duration, and it can be painful or uncomfortable. And it usually starts in the upper extremities and then progresses to the lower extremities. And you can get peeling, but that is a later finding. The adenopathy is usually anterior and cervical, unilateral, and it has to be greater than 1.5 centimeters in diameter to meet criteria. It is the least common principal clinical feature, but when it's present, it is often the first one you see. And then the mucosal, I apologize for all these fairly unpleasant photos. The mucosal changes are, you get redness, dryness, fissuring, peeling, cracking, bleeding lips. And the strawberry tongue is essentially just the tongue that looks like a strawberry. And you have erythema of the oropharyngeal mucosa. And if you see ulcers or exudate, you may want to question the KD diagnosis. So the differential with KD and those symptoms is broad, and many other syndromes or conditions mimic the KD symptoms. So if you have KD that does not meet classic criteria, you sometimes have atypical KD. And this, like I said before, occurs most commonly in infants who are at higher risk of developing coronary abnormalities. So we looked at patients with coronary abnormalities in KD, and 30% of those actually had incomplete or atypical KD. So it does not necessarily mean that their disease course is less severe. So we need to really hone in on these patients, and you want to obtain further KD workup in any child with prolonged fever and 2 or more classic KD findings, or any infant with a unexplained fever lasting more than a week. So this workup is summarized in this nice redesigned algorithm that you are probably familiar with. to highlight infants with fever for more than a week without other explanation, they added this directly into this to make sure that we're screening them with the appropriate laboratory assessments. And also kind of a reflexive echocardiogram if there's prolonged fever and inflammation. So to summarize that, the atypical KD workup includes the following studies. And something to remind you that coronary abnormalities are generally not seen until after the first week of illness. So the first kind of diagnostic echo will likely have no coronary abnormalities. And this does not rule out KD and or the need for treatment. So on to a few clinical conundrums that we've definitely come across. If you detect respiratory viruses and a kind of classic KD picture, this does not exclude a KD diagnosis. You can often have both. Adenovirus is probably the trickiest because they can, adenovirus infections can often share many of the same features with KD. So how do we distinguish the two? If you have adeno and exudative pharyngitis or conjunctivitis, this makes KD more unlikely. And then if you have the distinctive feature of KD, the extremity changes, a strawberry tongue or the peeling groin rash, that makes KD much more likely. And you may have both adeno and KD. So also please consider this condition in the following situation. So a child diagnosed with group A strep who does not improve with antibiotics. Fever and pyuria in an infant who you put on antibiotics for suspected UTI, but then develops a rash or reaction on antibiotics. Perhaps the irritable febrile infant who had a TAP and had some scant pleocytosis, but it was sterile and was diagnosed with partially treated meningitis. Or cervical lymphadenitis or retropharyngeal phlegmon, which does not improve with antibiotics. And interestingly, 5% of KD patients do present in a warm distributive shock that requires hemodynamic support. So on to the treatment, which we are all familiar with. The goals of the treatment are twofold. One is to reduce inflammation and damage, and two, to prevent coronary clots, prevent thrombosis. So IVIG high dose is, as soon as diagnosed within a week, is the gold standard. And please don't delay the treatment while waiting for the echocardiogram. It can definitely be done after you've given IVIG. Even with IVIG, 5% will develop coronary aneurysms and 1% will develop giant aneurysms. But with the high-dose IVIG, the percent that develop coronary aneurysms has fallen from about 25% to 5% in the modern era. And high-dose aspirin is given until afebrile for 2 to 3 days. And based on recent data from Japan and Europe, the 30 to 50 milligram per kilo per day dose, as opposed to the traditional 80 to 100, is shown to be equally effective at decreasing inflammation. However, the aspirin does not prevent coronary progression, but the IVIG does. So this is probably a problem that you encounter. What if the diagnosis is delayed or missed? And you want to still give IVIG if there is any evidence of ongoing inflammation, meaning fever, elevated inflammatory markers, or coronary artery aneurysms seen on echo. However, if the inflammation has completely resolved and echo is normal, you don't necessarily need the IVIG. And a couple other helpful tips. Hopefully, Motrin interferes with aspirin platelet inhibition and should be avoided in children with coronary artery aneurysms. And the measles, mumps, and varicella immunizations, per the Red Book, should be deferred for 11 months after receiving high-dose IVIG because of IVIG interference with the immune response. And Reye syndrome has actually been seen in patients with positive varicella or influenza and taking high-dose aspirin for KD, but it hasn't been reported in patients on low-dose aspirin. What does that mean for us? Mainly that patients with KD and families should receive their appropriate flu vaccines to kind of avoid this predicament if at all possible. And what if the fever recurs after IVIG, also known as IVIG resistance? So if you have recurrent fever after 36 hours after IVIG, this happens 10 to 20% in KD patients. You usually start with redosing IVIG. You can also consider a steroid, a methylpred pulse, or a TNF alpha antagonist infliximab. And we reserve other more of the heavy gun cyclosporin, anakinra, plasma exchange cyclophosphamide if you have really highly refractory KD. And most of these patients I would probably advise considering a 2 to 3 steroid taper to help quell the inflammation. And CRP versus ESR. CRP is a more timely, accurate marker of inflammation and response. ESR does lag behind and is falsely elevated by IVIG. So how do we prevent coronary clots? The highest risk for coronary clots happens in the first month and a half after the fever onset. This is because of a few different reasons. One, you get a thrombocytosis in KD, and 2, you get endothelial damage, and you have a kind of inflamed hypercoagulable state, all contributing to this risk, rare but real risk of coronary clots. So that is why after the high-dose aspirin, you go to a lower-dose antiplatelet therapy. It's to prevent the clots. And some patients with big coronaries will get anticoagulation, meaning Coumadin or Lovenox. So how frequently should your patients be echoed? In uncomplicated patients, you do it at the diagnosis, and this is a slightly revised recommendation from 2004, and then 1 to 2 weeks after treatment, and then again at 4 to 6 weeks after. If coronary aneurysms are present, you get them at least 2 times a week, actually, until coronaries have stopped progressing, and if they're giant, and this is a scientific term, giant, obtain weekly echo until day 45, then monthly until 3rd month. So hopefully you never see coronaries this big, but this just shows that there is a risk for progression, and then you can actually diagnose clot by echo in the bottom right. So that's why we get frequent echoes, to kind of track the progression and also to look for clots. So on to long-term management in my last 10 minutes. So Mark also mentioned these z-scores. They're just a fancy way to say standard deviations. So if someone has a z-score of positive 2, then they're in the 98th percentile. So based on z-scores, if the z-score of the coronaries is less than 2, then that means that there's quote-unquote no involvement. And then if the z-score is like between 5 to 10, that's a medium, and giant is greater than 10, or absolute dimension of greater than 8 millimeters. And this is a change from the previous document, and now it's all based on kind of normalized data, which we have more of. So based on risk, the AHA offers very specific recommendations on the frequency of cardiology visits, stress testing to look at inducible myocardial ischemia, angiography, risk factor assessment management, physical activity, reproductive counseling, and kind of medication use. And so I'll refer you to the table. Table 10 shows kind of long-term assessment counseling algorithms. It's very kind of marched out for you. So for instance, if you have no coronary involvement, you actually can be discharged from the cardiologist probably at the last follow-up echo if it's normal, so sometime between 4 weeks and a year, and then nothing kind of out of the ordinary in terms of counseling or assessments. However, if you have giant aneurysms, then that patient should be seen by a cardiologist every 3 months, be sent for inducible myocardial ischemia test, like a stress test, and sent for angiography within the first year, and maybe yearly thereafter, and then very frequent counseling and risk factor assessment and management. Same idea in terms of medications. So if your patient has a normal echo at 6 weeks, that patient most likely does not need any other therapies, and you can go ahead and discontinue the low-dose aspirin because they're through the most high-risk stage for coronary clots. However, if you have giant aneurysms, you're going to be on aspirin and probably Coumadin, Plavix, and maybe a beta blocker and a statin. So there's a quite variable range of therapy. So for no aneurysms, just to hammer home the point, physical activity should be promoted. They don't have any restrictions after 8 weeks. And there should, the long-term outcomes are good, if not better than normal. And long-term cardiology follow-up is not recommended. So this is for any patients with with no coronary artery changes or very transient dilation. However, if your patients have or had aneurysms, physical activity, like Mark also alluded to, should be still promoted, but stress tests, either exercise or echo, should guide participation in higher intensity sports and competition, and no collision sports on antiplatelet or anticoagulation. And for patients who have had aneurysms, thrombosis risk with oral estrogen needs to be considered, and alternative options need to be explored because of this risk for coronary clots. And considering pregnancy, please see a high-risk OB and adult cardiologist for a full, complete cardiac status update. And we all know that if these patients do have significant aneurysms, this can be a burdensome chronic condition. So these patients and families may benefit from professional psychosocial support. And they do require lifelong cardiology follow-up, so please plug them back in if they haven't seen their cardiologist in a while. So it sounds all doom and gloom, but this is a survival curve for patients with the worst case scenario, the giant aneurysms. And as you can see, the survival after 15 to 30 years is not horrible, considering how giant these aneurysms are. And the survival is about 88%. And this is, 30 years ago, 40 years ago. But this isn't without a significant burden. In these same patients with giant aneurysms, the majority of these patients need a coronary intervention, and about 15% do get heart attacks. And what about infective endocarditis prophylaxis? It's actually not required for KD patients regardless of the coronary size. So in conclusion, KD is an important cause of heart disease in children and adults, and primary providers must maintain a high level of suspicion to make this challenging diagnosis. And goals of care include reducing inflammation, preventing coronary aneurysms, preventing clot, and surveillance for worsening coronary disease or ischemic heart disease. And as with everything, successful long-term management requires a coordinated multidisciplinary approach. Thank you.